Anybody want to volunteer to be a patient
Ooh.
for this? We're going to be doing
Don't be
some
shy.
stuff with the lower extremity.
I can.
Okay. So,
Way to be brave.
Is it painful?
No.
You should have asked that before you went.
Yeah, no kidding.
so the first thing that I'm going to ask you obviously no back problems, no knee problems, no hip problems. Okay, we'll do the other way then. No problem. So, what I'm going to have you do at first is
You guys mind if we record?
so I'm going to have you come over here. So before I get talking about what joint manipulation is, we don't have a slant board, so we're going to make do with what we have. What I'm going to have you do is use this as if it's slant board, you know, like how you stretch calf muscle. So both legs on it. You're going to lean until you feel the calf stretch, and I want you to close your eyes. You're going to sit like that for 3 minutes. This is going to be a sensory illusion task that I'm going to use to demonstrate the effectiveness of joint manipulation on proprioception. So just make sure your eyes are closed. That's running. Okay, so there's multiple different ways to approach joint manipulation, generally divided into two types. We have our high velocity, low amplitude. So amplitude being force, right? The largest forces that we realistically use in the body are with the lumbar spine and the pelvis, and those are only 500 newtons. That's nothing compared to the forces that the body experiences going through everyday life. Going downstairs, you'll have double that, right? So some of the key concepts you'll be able to see on our graph over here, the force graph. The main thing that to really talk about is that idea of the pre-thrust phase or the preload phase. That's basically pulling all of the slack out of the soft tissue as we're setting up for the actual adjustment. That's done really more for a patient comfort thing. You can adjust from just nowhere, but it's a little more uncomfortable. Then we have our thrust phase and the resolution phase, which is basically the joint as it returns back to its normal position. With our low velocity adjustments, grades 1 through 4, also typically termed like Maitland's mobilizations is a common phrase for that. These guys can be done in a little different ways, but generally we're, as opposed to looking at like change over time and the force, we're looking at the force, but the frequency, the hertz that we're delivering the adjustment. Now, those adjustments can be delivered with a repeated thrust. They can also be delivered in a sustained fashion. In general, as you go up from grade 1 to 4, you're slowly increasing the force, but you might be decreasing the frequency of delivering the force. The graph on the right side actually shows a study where a physical therapist, they randomly took them and told them perform a grade 3, perform a grade 4, and that's what they measured there. And you can see that as you're trained in a certain way, you start to develop like that. In chiropractic, we do all of these different manipulation levels. I find that, based on the literature, grade 1, grade 2 mobilizations, really good for people that are in very, very acute pain and they can't tolerate fuller ranges of motion. Very good for just inputting some proprioception and getting the acute pain down so that you could potentially do more active base rehabilitation alongside. With high velocity, low amplitude adjustments, very good for more healthier people that have more chronic problems. And I find it's the best way to really get proprioceptive input into the body. All right, so keeping your eyes closed up here, you can go ahead and step off for me. I'm just going to be right here, take a step. We're now going to have you stand on your right leg. Just the right leg, just stand still. And so this is normally done on a force plate, and so you'd be able to see center of pressure. We're going to do our best to see a difference here. So you can see how he clearly biases towards that right side, maybe a little bit wobbly around the knee, right? The longer he's here, the more unsteady he gets. All right, so go back into that position. You can open your eyes to set yourself back up. We're gonna do a couple more seconds here to kind of replace that. And then we're gonna come over to the table and I'm gonna do 3 mobilizations. I'm gonna do one on his hip, one on knee, one on ankle, all in quick succession. Then we're gonna have him immediately stand back on the one leg, and hopefully, if all goes well, because like I said, this is normally done on a force plate, where you can really see the change in the center of pressure. We'll be able to see a more stable foot position in the ground. All right, so you can open your eyes briefly to come over to the table. And then I will have you lay down, feet over here. And when you lay down, your shoes are fine. So go ahead and close your eyes for me again. We want to try to remove the visual system from this as much as possible, just for the demonstration purposes. Okay, so I'm going to start up by the hip. There's a million different ways to manipulate all the joints. We're going to go some of the most basic here. Long axis traction for all three. Okay, so what I'm going to do with your right leg is I'm going to just reach in on the inner part of your thigh. I'm going to wrap my arm around the other side, okay? And because of the angle of the acetabulum, you want to bring the hip out about 15 degrees. And from this type of position, go ahead and grab the edge of the table for me, and you want to hold yourself in place. I'm going to load out the joint and then give a quick little pull. Okay? Very straightforward. Now for the knee, it's important with the knee that we don't go too low. You want to avoid the ankle. And so with this, we're going to come more straight in line with the anatomical position. And you can grab this a million different ways. You can pull it a million different ways. I know some people prefer to face the feet. I just prefer to do it this way. So I kind of wrap around, lock my thumbs, get a little tension, and pull. Did you feel that more in the knee compared to the hip before? Yeah. So then we come down to the foot and for the ankle. And so generally what we do with this, you kind of come right off the front of the tibia. You find roughly where the dome of the talus would be, under where your hand's at. You bring it into dorsiflexion, tension, pull. We'll do another one. There we go. All right. Now I'm going to have you stand up for me. Keep your eyes closed. We'll have you face the class. All right. Stand on one leg for me. Yep.
That's definitely more stable.
I would say it's a little bit better.
Yeah.
He's definitely, you might not have been able to see it up there, but he was more rolling towards the lateral aspect of his foot. It's a little more stable than before, but like I said, the visualization of this is a lot better with a force plate. This is a sensory confusion task that has been done since the early 2000s to kind of demonstrate what this does. I've even seen it done with single leg balance using the upper extremity, and it still has an effect. So that's
How does it do that?
how does it do that? It's sensory input. We don't know. And that's really the answer. We don't know. I personally believe it has to do with stimulating the cerebellum, especially through a lot of the feedback pathways and feed forward, especially. I think there's a lot of neglect in looking at some of those feed forward mechanisms for motor planning from the cerebellum, but nobody's really looked at it. So
What do you mean about feed it forward? Like predictive?
yeah, motor planning, essentially. Yeah.
The manipulations that you did in terms of like the joints, I imagine it almost immediately like, I guess, lifting off the pressure of those like maybe sensory nerves, and now all of a sudden maybe you have much more like different kinds of sensory information coming in.
Yeah, definitely. I mean, you're going to get a lot of stretch response within the joint as well. There's one thing that's definitely been overlooked with joint manipulation is how the skin plays a role in it as well with the proprioceptive aspect, because especially with that preload component, that's a big chunk of what you can stand with your eyes open now. That's a big chunk of what. That's a big chunk of what we're pulling out of that is all of the skin, the fascia, all of that, and we're getting to the point where you start to feel.
Did you know?
Which again comes from practice, but you start to feel the joint essentially as the next thing that's a give, and then you're delivering a manipulation.
Sorry, Greg.
Go ahead.
Who were the control groups on those studies? So how can you control that it is the
So
velocity manipulation and not?
Nice
How do you do it on the couch? and you touch the
Yeah,
joint
so
and-
the one study that is from, they used people that actually just, the control group was they laid on the table and didn't receive any input. So they laid down on the table and then immediately had adjustment. And now in that study, they only did one adjustment. I did do 3 here. But they were, again, it's much easier to visualize on a force plate.
Yes, no, I don't.
Yeah.
I think, to make it even a stronger case, maybe a good control group could be where you move, you don't manipulate, you move the joint so that there is from the receiver, there is let's call it connection with, you move the hip, you move the knee,
Yeah.
you move the ankle, so because,
Well,
then if then the high velocity thrust has a better outcome, then we know that the high velocity thrust is the.
So that feeds into another problem with joint manipulation research. How do you control it? How do you actually do a control group? You can't. People know when they're being manipulated. We've tried strategies where, like in chiropractic, we have these tables called drop tables. We've done systems where we've done drop groups, and we've taken people that have never been to a chiropractor before, and we would use our own leg to trigger the drop while not delivering force to the patient, and the patient still knows whether they're receiving a manipulation or not. Yeah, it's impossible to double blind people.
No, yeah.
So,
you can use a control.
There's no true control for joint manipulation. We typically compare it to either nothing. We might use mechanical-based ultrasound, so an intermittent pulsed ultrasound, or exercise. Exercise has traditionally been a very big one. Even the newest, well, not new at this point, but Jill Hayden's Cochrane review showed that exercise and manual therapies are basically the same when it comes to pain outcomes. And so all of those things are thrown together, but they're not equivalent in terms of what's actually happening in the body. But do they need to be equivalent? I don't think so. But
We have about 3 more minutes for questions, and then who is next? If the next person wants to start setting up their space.
It's Brian.
What about measuring blood flow?
So
Temperature changes to oxygen, or
I'm not super aware of anything about that. I do know that there's been fMRI studies showing increased activities in like S1, somatosensory cortex, and even with patients with pain, you'll see increases in the activity of the perioccipital gray matter, so increasing the descending pain modulation and even sympathetic and parasympathetic balance. But on the same end, when we look peripherally for some of those same responses, we haven't seen them yet. Like HRV, from my understanding, doesn't change with manipulation, even though we see some activity in the brain that might correlate with that. It doesn't seem to translate peripherally.
How long does the research last?
So that's another good question. I think it's highly variable for a lot of people. And there's been studies that have looked at a 24-hour washout and have found that the improvements have remained. There's been other studies with just a 2-hour washout that have found that there's no change after 2 hours. You're back to baseline. So one of the big challenges is finding the parameters that actually matter the most for this. And that's been the big shift with, especially in the world of chiropractic, looking at how the force is delivered and the parameters of force. And ideally, we eventually will get to the point where we actually start measuring the parameters of the tissue that we're adjusting into, because the best thing we have right now is functionally the force that goes into the patient and then the force that's transmitted out of the patient. And we have this loss of force between my contact with the patient and the table. We know that's transmitted into the patient and it's going to the patient, but what is it actually doing in the patient and how much that matters in the long term. So if we could functionally model the way the tissue behaves, you could get an even greater understanding of how the force works within the body.
Can you explain the force board, or I forgot what it was called?
Do you have a question?
Just the angle you had him at, that was
Yeah,
what
so
is
the angle
rationale?
doesn't necessarily matter. I've seen anything from 15 to 35 degrees, but you typically would just use a slant board for that, which is something you find in a lot of rehab clinics for stretching the calf musculature. It's just a board that you just do this on. And so the idea is with the stretch, you're basically sending an absolute ton of proprioceptive stretch response up to the brain, and it messes with balance. If we had more time, I could show you kind of other examples of that, but we don't have a ton of time. Yeah.
Thank you so much.